Hello, everyone. Good afternoon. My name is Daniele Magalhães. I'm the Senior Project Director at the Global Consortium on Climate and Health Education. I can't believe we are already in the final session of this training. Today, we are going to discuss building resilient and low carbon health system synergies and challenges. And as you know, we have interpretation in English, in French, Spanish, and Portuguese. You just need to click in the globe on your Zoom toolbar and choose your channel. So last session, building resilient and low carbon health systems, synergies and challenges. So today we're going to identify and leverage synergies between health system, climate resilience and decarbonization efforts. We will learn how to develop integrated strategies that rapidly advance both adaptation and mitigation goals within health systems. We are going to identify education and training programs that build health professionals' capacity for both climate resilience and low carbon operations. And we are going to create implementation pathways that manage trade-offs and maximize co-benefits between adaptation and mitigation efforts. The logistic, you already know. There will be a 19-minute sessions with a Q&A at the end, so please include your questions to the participant, to the speakers in the Q&A session. And the video recording will be available in 48 hours in our YouTube channel and in the course website. Your attendance is automatically recording when you using your personal Zoom link, and the YouTube. If you watch the videos in YouTube, it's not counted as attendance. And regarding the final exam, there will be 25 questions, multiple choice and true or false. You are going to receive the link today in your email and WhatsApp. You don't need to take the exam today. You will have until November 6th to finalize your exam. But you need to, there is no time limit. You can take 1 hour, 2 hours, 3 hours, 4, whatever.
Daniele, your slides are not advancing. I don't know if you've been.
No? Okay.
It says you paused screen sharing.
Okay, let's come back. Sorry. So I was here. Is that okay now? Okay, so the certificate will be issued by December 7th. And if you have any questions, you can contact Maggie and please check your email after this date. You don't need to contact us before this date, and if you didn't receive your certificate, please contact us. And if you watched 8 of the 11 sessions live and you score more than 70% in the final exam, you will be granted with a certificate. And in case you didn't, please join us in our WhatsApp group. And if you already in the WhatsApp group, even when the course finish, stay in the WhatsApp group, because we are going to share a lot of initiatives in the group. And if you are interested, you can receive that. So today we will have 4 presenters, 5. We will start with Judith Harvey. She's the technical consultant, Smart Hospital Initiative in St. Lucia, and we are going to include her bio in the chat, and I will pass over to Judith. Thank you so much, Judith.
Hello, everyone. I'm going to share my slides.
Can you adjust your camera to your face?
Pardon me?
start, yeah, thank you.
Okay, so I can start now.
Sure.
Yeah. So it's a pleasure to present the Smart Hospitals initiative in this forum, particularly looking at the smart way of navigating the trade-offs between adaptation to and mitigation of climate change. The Smart Hospitals initiative has enhanced the resilience and reduced the carbon footprints of health facilities, both achieving adaptation and mitigation, and focused on upgrading the health system infrastructure, therefore, to meet the challenge of climate change. I refer you to the website, the PAHO website, and the Smart Hospitals Toolkit for more details than are given in this presentation. The objectives of this session were identified by Daniele at the start, and this presentation will deal with 3 of them in particular. The presentation is going to look at synergies between adaptation and mitigation of climate change, as well as trade-offs, strategies for managing those trade-offs, and sometimes there are trade-offs also between health and efforts at adaptation and mitigation, and these will be highlighted because the nature of this forum is climate change and health. Scaling up also has challenges and specific issues associated with it. So to scale up adaptation means replication of smart interventions, which means more of those that have been already used in pilot or small scale projects, mainstreaming the smart concept into policies and plans, applying the smart concept outside the health system, for example, in community shelters or in schools, as has been done in the British Virgin Islands, and increasing the scope of smart interventions to create more adaptation and mitigation initiatives, as well as planning for the initiatives to be in place from the beginning in new facilities. So scaling up has a wide scope in the adaptation context. In the context of mitigation, mobilizing investment is critical, and we use an economic support tool created by Florida International University, the REST tool. And scaling up mitigation means changing the knowledge, attitude, and practice within the communities and the health facilities. The main themes of this presentation are going to be examples that illustrate the trade-offs and how to deal with the trade-offs between adaptation and mitigation. And these main themes deal with the following list. And so as we go through the presentation, examples under these categories will be shown: rising temperature, water issues, firefighting, energy issues, sustainability in terms of timber and vegetation, in terms of waste and chemicals and their effect on the environment, and maintenance. So in each case, adaptation versus mitigation will be considered. Sometimes also, in addition to that, health implications will be considered. And it is important to differentiate between the trade-off between adaptation and mitigation at small scale, which often occurs, as well as when scaling up and the intervention is more widespread. So we begin with an example where the trade-off between adaptation and mitigation can be considered both at small scale and at large scale. And these will be the initial examples. Tree branches become missiles during a hurricane. A recent hurricane, Melissa, struck Jamaica, and there are photos on social media showing coconut tree branches and other missiles. Unless passive cooling of a building is achieved by a type of vegetation that has very thin branches, it may be better to consider initiatives such as using potted plants, thinking outside the box, so that the plants can be stored away and do not become missiles during a hurricane. A win-win situation is the case of the hurricane shutters, which can act as sunshades. So we have a trade-off above and a synergy below. In the case of efficient cooling, and this has to do with the need for the maximum ventilation to be achieved, if there is a standby generator, for example, which has to be housed in a hurricane-resistant building, it can overheat if the building does not have enough natural ventilation. At the same time, more ventilation in a building can make it more vulnerable to hurricanes, not only because rain can blow inside louver windows, but also because the area of the windows must be protected very carefully to keep the building envelope sealed. And this is not only sealed against hurricane winds from the outside, but also sealed against escape of the cold air from air conditioning, which means that the cooling systems are not able to operate as efficiently. So this is a trade-off, and often problems have been found with overheating generators. So we have had this experience to deal with. Adapting to high temperatures and high humidity requires often the use of mechanical ventilation, air conditioning. So that adaptation measure requires the use of refrigerants, which often are greenhouse gases, and that does not contribute to mitigation. So to manage that trade-off is the choice of refrigerants is important. Adaptation also to the need for minimizing the heat due to rising temperature often creates temperature differences and condensation, because mitigation would require that one would not air condition the entire building if it is not absolutely necessary. But the pockets of warm air encourage growth of molds. And antifungal paints and chemicals are not always environmentally friendly, although they would prevent and treat mold. So this is a trade-off to be managed with the choice of the chemicals and paints used. Rainwater harvesting combines both climate change adaptation and mitigation, and to some extent is a win-win intervention. However, often these pumps are required to supply the rainwater from the tanks to the building. And the best solution we have found in Guyana, where it was commonly employed, was to pump the rainwater to a height and then to feed the hospital by gravity from those elevated tanks. But in the absence of these tall platforms, there is an electricity cost and a carbon footprint associated with using the electricity to pump the rainwater. Yet the stored rainwater is a reserve against drought, which is a feature of climate change. And also because if heavy rain occurs, often the intakes for the municipal water supply are clogged and damaged in our developing countries. Stormwater drainage in a green landscape can be challenging, yet mitigation calls for more green landscapes, but the leaves and the vegetation can block the drainage systems which are needed for adaptation to climate change and disposal of heavy flows of rainwater. Not only that, but weeds can grow in different forms of porous paving, which are meant to percolate the storm water and return it to the environment. And therefore, again, that is a trade-off to be managed largely by maintenance. These previous examples were cases where the trade-off between adaptation and mitigation was important, even when it was at small scale. But if widespread use of rainwater harvesting were to take place, scaling it up, then contamination of the water mains potentially could occur because there are so many users who may not all be equally responsible or educated about the risks. Likewise, mosquito breeding. So these are health challenges, trade-off, as opposed to the trade-off between mitigation and adaptation. But in addition to that, there is a trade-off between mitigation and adaptation in terms of the waste disposal associated with the water tanks, the pipes, and the equipment. And after the hurricane, there are many photos of tanks that have been destroyed, black plastic tanks, which contribute to the waste stream, for example. Fire extinguishers also illustrate the trade-off between adaptation and mitigation because many handheld extinguishers contain chemicals that contribute to global warming. Not only that, but fire hose reels require pumping systems to supply the water where it is needed. Yet, to adapt to climate change and the risk of wildfires requires a good fire suppression system in a health facility. Off-grid solar photovoltaic systems are an adaptation measure because they can provide power when the grid is down, for example, after an extreme weather event. Yet, the chemicals and the materials used for manufacture of the batteries, the panels, the inverters require careful handling and disposal to avoid environmental damage. There is another trade-off, and again, this is at small scale, where green landscapes, trees, can shade solar panels and reduce the efficiency and the amount of electricity produced. Not only that, but PV panels need to be washed periodically. And in washing them, the water from cleaning enters the storm drainage system as well as the rainwater harvesting tanks. And therefore, the trade-off requires management of the detergents used for that purpose. In scaling up the solar power supply, there are risks, and one of them is the instability in the electrical grid. To manage that, one consideration is to use microgrids. So there is not only a trade-off from the point of view of trying to mitigate climate change by using solar power and not achieving completely the desired result, but also because the panels can contribute to flying debris during a hurricane, as occurred in St. Thomas, shown in the photo here. And to manage that, it's important to have very wind-resistant connections for the entire ground-mounted solar panel system. So that is a trade-off between adaptation and mitigation to hurricanes, mitigation of climate change through solar power. Glare and reflections are health challenges for mental health. So that is a trade-off between health and mitigation. And finally, disposal of the equipment and materials. Wood is considered a sustainable material and highly recommended for mitigation efforts, but vulnerable both to insects and wet rot, and if not vulnerable, treated with chemicals that may not be environmentally friendly. The way to manage this is to consider hardwood or more resistant species. Not only that, but timber structures tend to be lightweight and vulnerable to strong winds. Many of the photos shown after Hurricane Melissa will depict lightweight timber roofs flying in the wind. And yet, to adapt to climate change and to have a heavy reinforced concrete roof would defeat the goal of mitigating climate change. Likewise, for fire resistance, care must be taken in designing timber elements to resist fire. And of course, fire being a risk from the adaptation point of view. Chemicals and waste management are also issues to carefully consider when scaling up adaptation efforts, because many of the materials and equipment used in creating adaptation initiatives will impact the environment. Likewise, waste at the end of life and during maintenance also impacts the environment. For example, the need to trim the trees regularly and often using diesel-powered chainsaws. So maintenance is important, and responsible maintenance helps to make adaptation without compromising mitigation of climate change. But maintenance is essential also from the health point of view, for example, for vector control. So human intervention is really geared at adaptation, trying to respond to nature and the threat of climate change. And the human interventions shown in the right of the table are responding to natural phenomena shown on the left of the table. But nonetheless, while extreme care can be taken, this captures the trade-off between high temperatures and wildfires and the need for cooling and fire safety and potential impacts on the environment, as mentioned in earlier examples. Again, the trade-off between strong winds and the need for hurricane safety, as mentioned in the example of the timber roofs, for example. Again, the trade-off between heavy rainfall and stormwater drainage being effective in spite of the risk of being clogged by vegetation, for example. And pests and vectors which can carry pathogens must be controlled by use of chemicals which are not always environmentally friendly. Green landscapes are desirable, but efforts to adapt to climate change and mitigate climate change will inevitably generate waste. And this photo shows actually the waste disposal site in St. Lucia, which caught fire spontaneously and was burning for a period of time before the fire could be controlled. That is to illustrate the issue. So we may conclude that scaling up adaptation efforts is feasible, but must be well considered, constantly reviewed, so that mitigation goals are not compromised. Thank you for your attention.
Thank you so much, Judith. Thank you for bringing your experience and to bring all these challenges and that we need to take in consideration. We need to have a balance between the how to adapt the health facilities to this disaster that's going to be exacerbated by climate change, but also how not to increase even more the carbon footprint. And connecting with this topic, I would like to invite our next speaker, Dr. Fernando Rementeria. He's a climate program manager for Latin American Healthcare Without Harm, and we are going to share his bio in the chat. Thank you so much, Fernando. Over to you.
Thank you. Thank you. I'm going to share my screen now. Perfect. Can you see my screen now?
It's loading. Yeah, perfect. Thank you.
Thank you. So, thank you so much for this opportunity of presenting on behalf of Healthcare Without Harm. Since I am representing specifically the work in Latin America and the Caribbean, I will make my presentation in Spanish. Okay? Perfecto. Bueno, entonces, después de esta introducción, yo les voy a compartir un poco
After
sobre
this
el trabajo que
introduction, I would like to tell
estado
you
realizando
a bit
desde
about the
Salud
work
Sin
that we
Daño, que
have
somos
been
una
doing from
organización que ha
Health
trabajado en más
Without
de 2
Harm.
décadas
We
con
have been
los
working for
sistemas de
over
salud
2
y
decades
establecimientos
with
de salud
health systems and
a nivel
health
mundial y
facilities
también en América
worldwide,
Latina y el
and
Caribe.
also, of course,
Y
in
nos
Latin America and
enfocamos
the
en el
Caribbean.
tema
We
de adaptación
focus
climática
on climate
para
adaptation
reducir
to
la vulnerabilidad
reduce
del sector de la salud
the
y también el tema de
vulnerability of
mitigación
the health
climática para
sector.
apoyar los
And we
procesos de
also focus on
descarbonización
climate
en los
mitigation to
sistemas de
support
establecimientos de salud
decarbonization processes
y
in
entendiendo
healthcare
también que
facilities.
la crisis
We
climática
also
está muy
understand that
ligada
the
al consumo
climate
de
crisis is
plásticos.
very much connected
Tenemos un
to
tercer
plastic
objetivo que está
consumption.
ligado al
We have a
proceso de
third objective
desplastificación
that
del sector
is
de la salud.
that has to do with
Un segundito,
removing
voy a
plastics from the
tratar de
health
buscar.
sector.
Listo. Ahora sí. Bueno, entonces nosotros como Salud Sin
Okay.
Daño
As
apoyamos
Salud
al
Sin
sector de la
Daño or
salud
Health
y
Without Harm,
coordinamos
we
lo que es
support
una
the health
red
system and
global
we
de
coordinate
hospitales
a
verdes y
global
saludables
network of
en la
green and
que
healthy
los
hospitals
establecimientos de salud que estén
where
interesados
the health
en formar parte de esta
hospitals
red
interested in being
pueden
part
de
of
forma
this network
voluntaria
can
acceder y
voluntarily
aprender de otros establecimientos
take
de salud
part
que
and
también
learn
tienen
from
el
other
interés
health
de
facilities
trabajar
that
el
are
tema
also
de
interested
sostenibilidad
in
y de acción
working with
climática.
sustainability and
Tenemos
climate
en la pantalla
action.
las diferentes regiones en
On the
donde
screen, we can
nuestra
see
red
the
colabora
various
con los
region
sistemas de
where our
salud, con los
network collaborates
hospitales
with health
y también
systems,
nosotros como Salud Sin Daño
hospitals,
generamos
and
recursos
as health
técnicos
care
tanto de
without harm, we
adaptación, de
also
mitigación,
produce
de
technical
compras
resources
sostenibles
for
para que
adaptation,
los hospitales
mitigation,
puedan avanzar
sustainable
en el proceso
purchasing,
de
so that
descarbonización y
hospitals
de
can
resiliencia climática.
advance in the
En
decarbonization and
estos
climate
procesos
resilience
tenemos muchos
process.
espacios donde
In,
los
uh,
establecimientos
in
pueden
these
compartir lo
processes, there
que
are
les ha
many opportunities
funcionado y
for
las áreas de
hospitals to
oportunidad que
share what
tienen
has worked
en
for
el
them
contexto de acción
within
climática.
the climate
Entonces, cuando
action
hablamos de
arena.
acción climática,
When we talk about climate
tenemos
action,
una guía
we
de
have
hospitales verdes y
a
saludables
guide
que tiene
for
estos
green
puntos
and healthy
que
hospitals
buscamos
that includes
que
these
incluyan los elementos
items.
de acción climática,
We
tanto de
we want
mitigación
to
como de
include
adaptación,
both mitigation and
desde el
adaptation
aspecto del
climate
liderazgo hasta el
actions. So
manejo de los
this
insumos como
includes
los químicos,
leadership,
los
also
fármacos, la gestión de
managing
residuos,
substances such as chemicals, also the energy within the hospital, water, waste, the efficient management of water as well. So these components in this guide we suggest can be addressed through the mitigation and adaptation lens. Just a few examples. What can we share with you from our organization regarding what is being done in the area of adaptation and mitigation? Health facilities are implementing mitigation and adaptation actions. That's true. However, when it comes to producing these actions or developing them, they are not doing this in a connected way. They are taken separately. And this means that people have to work twice as hard, or maybe these actions do not yield the right benefits following the actions implemented in the hospitals. We have also identified that several actions already implemented have yielded adaptation benefits, but they are not identified as such in the sustainability process. Why? Because there hasn't been the necessary capacity building, maybe because they haven't been analyzed under an adaptation lens. But it doesn't mean that the hospital is not addressing this issue. I'll give you some examples later on. We've also realized that in order to address both elements of climate action, hospitals do not always have the necessary capacity to do so, meaning that maybe the sustainability department or environmental health department is very small, or maybe it lacks the technical and financial resources to do both things. Another important point is that we still have an opportunity to include different health professionals when it comes to climate action, adaptation and mitigation climate action. We must do this, and it's a challenge. We need to engage them more actively in climate change action. Examples, both for mitigation and adaptation, hospitals and healthcare facilities must have or need a strategic framework clearly stating what they're going to do. They need to have sustainability as an objective. They need to have partnerships that will allow them to implement the mitigation and adaptation actions. National partnerships, maybe they can be connected to NDCs, or they might work with other organizations, other NGOs that might help them attain their goals, because this strengthens their future activities. And this also should be connected to the Sustainable Development Goals. This is essential to have the support of higher authorities when it comes to adaptation, climate adaptation and mitigation efforts. Also, analysis baselines for adaptation and mitigation. They are the foundation that will allow us to implement climate action focused on the potential benefits. This is an example of a climate vulnerability analysis that goes over the building's vulnerabilities, but not just that. It also focuses on the risks within the communities where the hospital is located, and also what the emergency lines are going to be like, how floods and landslides affect the area. So we need to think beyond our hospitals to conduct this analysis. Regarding mitigation, the baseline needs to focus on assessing our carbon footprint so that we can say, from this or that year, we have annually calculated our footprint and we have managed to reduce it by a certain percentage.
a través de las diferentes categorías de
So this tool has
generación
been
de
measured
emisiones
to
y los hospitales han podido
has been
analizar
developed to measure
qué áreas
carbon
necesitan
footprints
priorizar
with different
para reducir
categories
sus
and
emisiones.
emission
Puede ser
generation
que
and all
sean a
that.
través de las emisiones
And hospitals can
fugitivas,
focus on the
que
areas
nosotros
where
les
they need to
llamamos
reduce their
aquellas que están
emissions. This
ligadas
might be the
a las emisiones
fugitive
por refrigerantes o
emissions.
por
They
gases
have to do
anestésicos,
with
o identifican que son
anesthetic
emisiones
gas
ligadas más al tema
emissions
de
or cooling
residuos.
emissions
Eh,
or waste-related
Ahora,
emissions.
hay varios ejemplos que me gustaría recalcar en cuestión de
There are
trabajar
several
con otras
examples I would like to
organizaciones y con
share with
otras
you
alianzas del
regarding
gobierno para llevar a cabo
work with
acciones de
other
mitigación y
organizations or
adaptación.
the government in order
Aquí
to
en
implement
la zona
mitigation and
patagónica en
adaptation
Chile, lograron
actions.
trabajar con
This is
este
in
organismo
Chile's Patagonia.
nacional
They
en tema
worked with this national
del
organization
uso y
addressing
manejo
the
de
use
bosques
and
para poder llevar a
management of
cabo una actividad
forests
de
in order
adaptación climática
to implement a
y
climate
llevan a cabo
adaptation
también su medición de huella de
plan.
carbono.
And they also
Entonces van
assess
llevando a
their
cabo
carbon footprint.
estos procesos
So what
donde
they
van
do is
trabajando en
implement
paralelo el tema de
processes where they
adaptación y
work
mitigación.
together on climate
También
change
hay otros
mitigation and
establecimientos que han
adaptation.
llevado a
There are
cabo
other
una
centers
perspectiva
as well that
diferente.
have
Por
implemented a different
ejemplo, la Clínica
perspective.
Bíblica
For
en Costa
instance,
Rica,
the
su
Clínica
marco
Bíblica in Costa
metodológico para
Rica,
atender mitigación
they
y
have a
adaptación
methodological
es a
framework to
través
address
del concepto
mitigation
de
and adaptation.
materialidad.
They work
Y
with the
ellos
concept of
dijeron, lo vamos a revisar a través de
materiality or
estándares,
materialidad in
vamos a
Spanish.
revisar tanto
They said,
nuestro
we're going to
impacto
check or assess all
que se
this
hace a
through
través de lo
standards.
que
We're
se
going to
llama
assess our
materialidad
impact,
e
and this is done
impacto
through
y
materialidad, the
utilizan
impacto or
ciertos estándares
impact
específicos para eso,
significance,
incluyendo
and they use specific
estándares para
standards to do
medir la
that,
huella de carbono,
including
pero
standards to
también la parte
assess carbon
mitigación es
footprints.
entender
But
a través de la
also,
materialidad
mitigation
financiera
entails
cómo impactan estos
understanding
riesgos
these
a las
impacts
finanzas del hospital
through
y a través de estos
finances. So, how
estándares,
these risks
tanto de
affect the
materialidad financiera
hospital.
como materialidad de
And through
impacto,
these
este
standards,
hospital, la Clínica Bíblica, han
finances, and impact,
trabajado el
this
tema de
Clínica
adaptación y de
Bíblica hospital
mitigación.
has addressed the issue of
Otro ejemplo de
adaptation
cómo
and
se llevan a
mitigation.
cabo estas
Another
sinergias de
example of
adaptación y
how
mitigación
this
lo tenemos
these adaptation
con
mitigation
este
actions
ejemplo en
are
Bogotá, en
implemented. Have
Colombia,
a look at this
donde
example in
llevaron a
Bogota,
cabo
Colombia,
actividades
where
de
they
jardines,
conducted
huertos urbanos
these activities,
y
urban orchards,
lograron
urban
cuantificar
gardens,
cuántas
and they
emisiones de gases
managed
de
to
efecto invernadero de
quantify
dióxido de
the
carbono equivalente eran evitadas a
GAG
través
gas
de
emissions,
estos
CO2
huertos.
emissions were
Entonces, al momento de tener estos
not
huertos
emitted through these orchards.
urbanos dentro
So
del
these urban
establecimiento de salud,
orchards, if
generas
you have
no
them in a
solo una
hospital, in a
cohesión
health
comunitaria,
center,
sino que también
you
empiezas a
have
generar
a
mayor
community
independencia de las cadenas de
engagement,
suministro de
but also
alimentos, ¿no?
you
Que
become more
sabemos que pueden
independent
llegar
from
a ser
food supply
alteradas por
chains,
los riesgos
which we
climáticos
know can
y se
be
empieza a hacer
modified by
un
climate
proceso de
risks. This
concientización de
starts an
también
awareness
lo que
raising
consumes puede ser
process,
local
meaning that
y es menos
you can let
propenso
people
a
know you can eat
disrupciones
locally,
en la cadena de
and
suministro.
that
Esto
food is
funciona no
less
solo
likely to
para
be
los productos
disrupted
orgánicos, sino
in the
también
supply
para los
chain.
otros productos, por ejemplo,
This
los
works
plásticos.
for organic
También este
food, but
mismo
also
hospital
it can
en
also apply to
Colombia
other products
trabaja en
like
el tema
plastic.
de
This
proyección
same
de
health center or hospital in Colombia
futuras
works
medidas. Aquí
on
tenemos, por ejemplo,
um,
un
forecasting
esfuerzo
future
para
action.
cuantificar
This
cuántos
is an
paneles solares
effort
se
to
utilizan.
quantify how
Y
many
con este
solar
ejemplo lo
panels are
que quiero ir
used.
es que
And
se
this
pueden empezar a
example is
trabajar
trying to
ciertas
show that we
medidas
can
que, como
start
vimos,
working
ya
on
se están
some
implementando,
actions that,
mientras se van
as we said
avanzando y
before, are
otras
already
medidas
being
que requieren
implemented
un poquito
as
más de
we advance
análisis,
or make progress
de
in other
factibilidad,
actions that
de
require more
costo-beneficio. Y
further
es aquí también
analysis,
cuando tienes oportunidad
feasibility,
de
cost benefit
ver
analysis,
en tu
etc.
análisis, bueno, sabemos que
And
con el
this
panel
allows you to
solar vamos a
see,
reducir
if
nuestras
you conduct this
emisiones
analysis,
y
for
también
instance, that with
generaremos
solar
cierta
panels, we can reduce our
independencia
emissions and
a
we
la
will
red de
become
suministro
more
eléctrico
independent from
que
the
sabemos que puede
uh,
ser
power
vulnerable a
grid,
los
which
riesgos
we know
climáticos.
can be affected
Entonces,
by
cada
climate
oportunidad de
risks.
acción y nueva implementación que tengamos puede realizarse bajo este
And
enfoque de
so
los
each
cobeneficios
new
entre adaptación y
action can
mitigación.
be addressed from this
Otro
approach
ejemplo es el de
of
la clínica
co-benefits and
MEDS en Chile.
mitigation.
Ellos han
Another
trabajado
example we
muy
have is this
fuerte en el
MEDS
tema
clinic
de
in Chile,
manejo de
where
el
they have
agua,
worked
gestión hídrica de
on
manera sostenible.
managing
Han
water in a
trabajado en
sustainable
el
way.
uso
They have
de
worked
en el uso
on
de tecnologías para el ahorro hídrico,
using
para el ahorro
technologies to
del
save
agua con sus
water
equipamientos,
in their
trabajando
equipment,
en jardines que son de bajo consumo hídrico
using
y teniendo
gardens
campañas
that use small amounts of water. And they
concientización para el
also
consumo del agua.
have done
Pero aquí un
campaigns
detalle,
to raise
ellos
awareness
no
about the
veían
use of
este
water. But
proceso
a
como un proceso
detail
de
is
adaptación,
that they
sino
didn't see
realmente
this
como
as an
gestión
adaptation
sostenible
process.
de los
It was
recursos.
just a
Pero
sustainable
aquí la
management of
oportunidad es
resources.
revisar
But
cómo
the
estas
opportunity
acciones
here is
ayudan no
to
solo
look
al
at how
proceso de
these
adaptación del
actions
hospital,
help
sino de la
not only
comunidad,
in the
porque
adaptation
estás
process of the
ayudando como
hospital, but
infraestructura a
also in the
reducir
community, because
el
as an
consumo hídrico de tu
infrastructure, you
comunidad
are
y
contributing to reduce
generas
the
mayor
use of water in your
resiliencia o
community,
capacidad adaptativa ante
building more
sequías.
resilience or adaptive
Y también
capacity
al
to
reducir tu
droughts
consumo
as well.
hídrico,
And also by
se
cutting
utiliza
down
menos
the use of
energía para el
water,
bombeo
you are using less
del agua
power
dentro del
to pump
sistema
that water within
de agua potable y
the
de su
water
distribución.
system
Entonces, la
and
tarea
distribution.
aquí, la
And
oportunidad es
so
revisar cómo
the
las acciones que ya se
opportunity
están llevando
here
a
is to
cabo
look
traen
at
estos
how
co-beneficios de
actions that
adaptación y
are already being
mitigación.
carried out also
Aquí otro
bring
ejemplo
mitigation and adaptation benefits.
a mí me parece muy bonito
This is
del
another
Instituto
example
Roosevelt
that
en
I think
Colombia.
it's
También ellos
wonderful
lograron
from in the
trabajar el
Roosevelt
tema
Institute in
de
Colombia,
huertos urbanos,
where they work
de
on
generar con sus
urban
pacientes,
veggie
incluirlos
gardens,
el tema de cosechar y
working with their
sembrar tus propios
patients and
productos
including
y llevar a
them
cabo menús ecológicos.
to
Entonces
sow
no
and
solo van en
harvest
la
their
parte de
own
los residuos
produce.
que también se
And
utilizan
it
para generar
brings
composta,
benefits not
sino que
just for waste
también va más
management
allá
because they
de
are
cómo
doing
el paciente
compost,
se
but it
involucra y
also
cómo comunicamos
involves the
nuestros esfuerzos como
patient, and it
sistemas de
has to
salud
do
en el tema
with
de
how we
adaptación y
communicate
mitigación.
our
Y esta
mitigation and
forma de
adaptation
comunicar también es
efforts
una
as a
oportunidad para
healthcare
decir, miren,
system. And this
tenemos
is also an
acciones que
opportunity
pueden
to
beneficiar tanto
show
en
that we
adaptación como
have
en mitigación
actions
climática.
that can
Es,
help
es
both
una
with
oportunidad
adaptation and
el ver y
mitigation.
analizar
And
cómo lo
so this is
hacemos.
an opportunity
Y
to
bueno, ya
look
nada más
at
para
how we
cerrar
do it, not just
y
what we do.
reconociendo que
And
Salud
in
Sin Daño ha
closing,
tenido la
and
oportunidad
to
de ir
acknowledge
trabajando y
that
escuchando a más
healthcare
de
without
2.000
harm,
establecimientos de
we
salud,
have worked with
1.500
over
aproximadamente en la región
2,000,
de América Latina
about
y el Caribe, nos damos cuenta de que en los
2,500
espacios en los
healthcare
que
facilities from
coordinamos
around the
estas
region
actividades
in Latin
aprenden
America. And
mucho
we see
entre lo que
that
funciona en
we
Colombia y
learn
lo
a lot
que
from what
funciona en
works, for example,
Chile,
in
a pesar de
Colombia,
que son
in Chile,
diferentes contextos
even
y
if the
diferentes
context is
circunstancias,
different, even if the
siempre hay
circumstances are
procesos de
different,
innovación
there
y
are
de lo que
always
también se llama
innovation
tropicalización
processes.
a
There's always
las
the
realidades y los
tropicalization
contextos de cada
is something
establecimiento.
that works
También nos
for
hemos
each
dado cuenta
establishment.
que
And
cuando
we have
hay
also
normas
realized
a
that
nivel
when there are
nacional,
regulations
estándares
or standards
de
for
edificación o de que
buildings at the
tienen que
national
trabajar en el
level,
tema de acción
or that when
climática,
they are
los hospitales
mandated
avanzan más
to work
rápido
on
en el establecimiento,
environmental
por ejemplo,
issues,
de medición
the
de la huella de
facilities
carbono
move
o de
forward
implementar
quicker, for
medidas de
example,
resiliencia
measuring their
climática en la
carbon footprint
infraestructura.
or
Entonces, no
implementing
solo tiene que ser el
adaptation or
trabajo del establecimiento
mitigation
de salud,
measures in their
sino cómo está
infrastructure.
ligado a
So
las
it's not
normas y a las
just
leyes que
the
pueden ser
facility itself,
que
but
pueden ser
also how that
aplicadas dentro
connects
de
to
los esfuerzos
the
de los establecimientos de
regulations that
salud.
can be
Y finalmente,
applied to their efforts.
utilizar
And
los
finally,
espacios, los departamentos
using
que ya
spaces,
existen en los establecimientos de salud,
the
por ejemplo, el
departments or
departamento
offices that
de
already
manejo de
exist
residuos o el
within healthcare
departamento
facilities, for example,
de
waste
gestión de
management
los recursos
or
o de
resource
gestión de
management
los residuos sólidos.
or solid waste
Trabajar con
management
ellos
department.
para que desde
Working with them is
sus
important so that
actividades se vaya
in
incluyendo el tema
their
de mitigación y
activities, they can
adaptación.
include adaptation and
Es muy
mitigation.
útil
It's very useful because we don't have to start from zero. We have teams already in place, they can be trained, and they can streamline mitigation and adaptation and climate change into their daily activities. And now in closing, I'm going to focus more on the individual actions. What I presented so far was what we can do with as healthcare facilities, but we also work in our organization on building capacities for healthcare professionals individually, understanding that for these changes to take place in healthcare facilities, hospitals, and systems, nurses, doctors need to be leaders. They need to be trained, and they need to know how to communicate the issue to the directors, to officials, so that these changes and transformations can actually happen first starting in their community, and also why not going further beyond that and lead communication, the conversations around climate change. And with this, I finish my presentation. Thank you.
Thank you so much, Fernando. Thank you so much for all this exploring everything that the health care without harm is doing in Latin America. Super important, and also to see that you are also using nature-based solutions to bring health benefits and to also improve the reduce the emission of greenhouse gases. And it's perfect how you ended, because it will connect with our next speaker on how to engage the hospital administration and the hospital leaders on this mitigation efforts. And I would like to invite Dr. Miles Sargent, who is the Executive Director at the Canadian Coalition for Green Healthcare. And Dr. Miles, I will share for you your presentation, and you can start whenever you are ready.
Thank you so much, and thank you to the wonderful speakers before me. Such incredible work happening all around the world. It's very motivating. And thank you for inviting me to speak today. Yes, I am a family doctor in Canada and the executive director of the Coalition for Green Healthcare, which has been around for 25 years. And this is essentially a Canadian case study. Next slide, please. So this is the Canadian Coalition for Green Healthcare. This is our North Star. We are building a health system that heals people and the planet, and our vision, a sustainable, resilient, and equitable health system for all. Next slide. I am showing you a study we published about 1.5 years ago, which compared the footprint of a day in hospital in terms of kilograms of CO2 to long-term care and to home care. The data, the bars on the left, are from British Columbia. This was scope 1 and 2. You can see a hospital was about 30 kilograms for a day. Long-term care or nursing home was 8, and home care was less than 2. And then my friend Jérôme Robes from Laval, Quebec, who's also my boss at the coalition, did this study, which showed hospitals to be about 23, long-term care to be 2.3. Quebec happens to have an almost perfect energy grid, and that's partly why their numbers are lower. But the point is, hospitals, as we know, are much higher in footprint. Next slide. Jérôme did also look at scope 3, and then you can the effect is magnified even more on the right. So those are the original green bars you just saw 10 seconds ago, and they are dwarfed by the blue bars, which are supply chain, 230 kilograms CO2 and 35 for the long-term care. So we need to look at our hospitals. Next slide, please. So we made this article trying to make it easy for leadership to think about their hospitals. This is a 200-bed hospital in a Canadian context. The fruits on the tree are the different initiatives you can take. And the orange fruits are initiatives which save you 100 tons of CO2 per year if you take them on. On the left is a logarithmic scale showing the cost. Cost neutral is 0, as you can see, so savings toward the bottom and cost toward the top. If you look at the $10,000 range, which is in the scope of a hospital, is not a lot of money. Most of these things are essentially cost neutral or cost saving. The greatest one of all, you can see deprescribing on the bottom right. That is prescribing less medications. I'm going to talk about that in more detail. Saves a hospital that size about $500,000 per year, and is one of the big fruits in the tree. You're welcome to have all my slides. I know I do go through them quickly. Next slide. I think we have a lot of experts here. I won't spend a lot of time on this. This is a slide from Environment and Climate Change Canada, and I've summarized it looking at hospital-related greenhouse gases. CO2, as people may know, is the global warming potential of 1 unit. Methane from food waste, 83 times greater. Nitrous oxide or laughing gas, 273 times greater. And desflurane, the anesthetic gas, 2,500 times greater. I'm happy to say in Canada, we've actually not just banned desflurane at a number of hospitals, but provinces are banning it altogether. Next slide. And a life cycle analysis of a mask. A mask in terms of kilograms of CO2 is only 0.02 kilograms. Does not seem like a big deal. Next slide. And this is Maria from the Netherlands, and we have her permission to use her slide. Her website's in the bottom right. She is an artist from the Netherlands who had a breast reconstruction surgery, and she asked her surgeon if she could save all the waste. And so this is why one little mask matters. We make a lot of waste in healthcare. Next slide. So if you're taking this on at a hospital level, item number 1 is getting leadership at the top to take this on as an important initiative. What is your strategy? And you can have different strategies. There's different ways of taking this on. I've listed a few there. And you definitely need a person most responsible. And hopefully that person is high up in the organization, as high as vice president. Next slide. Again, supply chain is huge because we are not using a circular economy as much as we should. I often talk about the journey of a gown, where you dig it out of the ground and you ship it to manufacturing, you ship it to packaging, you ship it to the hospital. I might wear it as a physician for 30 seconds in some cases, and then we ship it to the dump. This is a broken system. Now, the topic today is mitigation and resiliency. So we understand the mitigation side of that. I'm going to show the next slide here, thank you, which is the journey, I'm going to call it the journey of a computer, which was done by the Copenhagen Business School. This was, I believe this was done during COVID, really looking at supply chain disruptions. There are a couple of different pathways here. You can follow the numbers. But for a product to get to Canada at the top left, it has a long journey to travel. Not only is there a huge footprint here from the travel, but there are many, many places that this can break down and make our system in Canada less resilient because we cannot get the product. Next slide. Drugs and devices, medications in the famous NHS Lancet study from 2021, Imogene et al., talked about medications being 22% of the footprint. So as a physician, one of the biggest things I know we can do is to prescribe less meds. And in Canada, we as physicians need to do what are called QI projects, quality improvement projects. Every 5 years, we need to do a project. I'm going to show you one in a minute, which I did at our hospital. Next slide. When we saw the journey of a computer, we were very interested as a group, and we decided to try to find the journey of a pill, and we picked clonazepam. We worked with the engineering department at McMaster University, and 3 master's students took this on as a project. This was published about 6 months ago in the Canadian Family Medicine Journal. There are many, many pathways to make clonazepam, which is a sleeping pill. It is an overprescribed medication. It has addictive properties. It has a lot of harms. it is overprescribed. We can do a lot better. And we were curious how long the journey is. We were not going to find the kilogram CO2 because we don't know what goes on in the buildings. Bottom line, this journey is 63,000 kilometers to get to a patient in Vancouver. And then, of course, it ends up in the urine and back into the water. Next slide. So at the hospital I work at a few years ago, our QI project, we looked at the number of medications. We are a chronic care, complex care hospital. Our patients all come from acute care. They were coming to us on 19 medications each. Most of our patients are older and have frailty, but 19 meds is a lot of medications, 13 regular meds, 6 as needed. So then we looked at which classes we felt we could do better as a group to deprescribe. And a couple examples were low molecular weight heparin. And again, clonazepam was another one on that list. And so we worked with the thrombosis team to create a new protocol, and we're doing much better now. Next slide. Transportation, virtual care. Clearly, virtual care cuts down on transportation. In remote areas in Canada, there are stories of people traveling hundreds of kilometers to have a foot ulcer, for example, looked at in person. Why can't we be doing this virtually? It would save a 500, 600 kilometer round trip. It also makes our system more resilient because we're not dependent on getting to the clinic in storms, etc. So moving to a more virtual medicine would be good. Next slide, please. Food. Plant-rich eating, I think everyone here knows the benefits of plant-rich eating, but the point I want to make is that where I live in Ontario, our hospitals, a study done a few years ago, showed that the hospitals in Ontario, from field to plate, the food travels 4,500 kilometers. A meal travels a total of 4,500 kilometers. We can be growing locally. We do have farmers in our province. Next slide. For the sake of time, I won't spend a lot of time on that. Of course, kilograms CO2, you've got meat on the left, and then moving into dairy and fish, and then into the vegetables. And as your grandma told you, eat more broccoli and tomatoes. Next slide. So natural systems, this might be my favorite topic. Trees have a ton of benefits. They have benefits for humans. Humans in hospitals looking out the window at trees are going to get better faster than looking at a brick wall. So lots of benefits to trees. We do, next slide, please. We do plant at the hospitals in town. This is the Hamilton General, which is in the very heart of our heat island in our town. So this is also helping to cool the city. We've done about 6 plantings at Hamilton General. Next slide. We also bring medical students out to plant, and this is obviously good for climate grief and for them giving back to society. And this is a group from about 2 or 3 years ago. They're always keen to plant. And of course, there are the natural-based solutions for resiliency, both in terms of heat impact and in terms of flooding. So lots of benefits to planting trees. Next slide. Now, this is a complete shift in this conversation today. Where do you want to be when you die? I wish I had time to do a little poll here and a show of hands. Who wants to die in hospital? Who wants to die in a nursing home? And who wants to die at home? When I ask this question, almost everybody puts their hand up for dying at home. Next slide. So if we go back to the same graphic I showed earlier, and we take a different lens, yes, we do need to decrease that hospital bar and make a day in hospital less intense in terms of CO2. But the bigger picture is we need to decrease our reliance on hospitals. Next slide. As part of that study, we looked at use of the system, of the healthcare system over the course of our lives. These graphs are all what we in Canada call hockey stick graphs. Starting on the left, you're a baby. Moving over to the right, you're 90 on each of these. The top left is polypharmacy, again, medications, and then health expenditures. And then also we have days in hospital there. The point is, all of these things have a direct relationship to greenhouse gases. Next slide. This is a closer look at days in hospital, and days in hospital, of course, go up as we get older. In this case, around 45, 50, the curve starts to go up in Canada. That's when we start to get sicker and stay in hospital. However, this is not just because of the development of chronic disease. This is also because it is the final year of life and we are now dying. And if you look at the mortality graph, it is almost exactly the same. We are now ending up in hospital, dying in hospital, and we don't want to be dying in hospital. What does this have to do with resiliency? To have a resilient system, you cannot rely on your acute care system to take care of everyone. When there is a heat wave or a severe heat dome, we cannot all go to the emergency department. We cannot all expect to be admitted to hospital. Next slide. So in the Canadian context, sadly, there are 3 million days per year of people in hospital waiting to go home or to go to long-term care. We call these alternate level of care, ALC days. This is 18% of our acute care beds are people waiting to go home and leave because we do not have enough home care. I expect this is a problem in many countries. We need to start shifting to taking care of people at home. It is better for mitigation and it is better for resiliency not to be so dependent on our hospitals. Next slide. So what can we do about this? The top thing here, this falls under education, is actually asking our patients, both upstream in the primary care office or family physician's office, what are your goals of care? And there are opportunities to do this when a patient is sick, has just been released from hospital, has a new chronic disease. There are opportunities to have this discussion. Next slide. And so I'm shifting to the work we do within primary care or family physicians' offices. We made a Green Office Toolkit in 2018. We updated it in 2023. Next slide. And part of what we talk about is, I'm just saying, is what we call end-of-life care and helping physicians and nurses have those difficult conversations with people long before they end up in hospital. Because again, 87% of Canadians want to die at home, and over 50% of Canadians end up dying in hospital. And really, this is one of the big ways we need to shift. This is to have these conversations early with people who are becoming frail. Next slide. And also in terms of prevention, it's my sense that we are not talking about prevention enough in the climate space. How can we prevent disease? Another article we wrote, A Kilo for a Ton, the concept that yes, everything that we use in healthcare does have a footprint. Next slide, please. However, if that footprint is well less than a kilo and it saves you a ton of healthcare in terms of disease and hospitalization down the road, we do need to be looking at the things which we underuse. Underuse is actually more of a problem than overuse. What do we underuse in Canada? We do a great job on vaccines. We could do better. How can we do better on vaccines to prevent disease? How can we do better on certain screening tests? Next slide. So as part of this article, we made the website called Echo Orders. And we do look at every specialty and what you might do within your own specialty that, yes, although it has a small carbon footprint to do that item, it saves you hospitalization down the road. And one example, I'm going to use cardiology here, is smoking cessation counseling and smoking cessation products like pharmacotherapy. Yes, it has a footprint, but clearly big benefits in terms of preventing heart, lung cancer diseases. Next slide. So we believe that environmental sustainability does align with an excellent patient care. It aligns with a more resilient system and less dependence on a hospital system. It makes our system more efficient and it saves money. Next slide. These are just a final slide to show how you can reach us. We have the Canadian Coalition website, Peach Health Ontario, that's our provincial website. And this is the primary care website. And thank you so much to Lisa for saving the day for me and making a nice job of these slides. And thanks again for having me.
Thank you so much. And I know that it was really, really quick. And because I know that the Canadian Coalition is doing a lot, and I really recommend all of you to go to their website and take a look at what they are doing. And they have trainings, they have amazing things that can be used in your countries as well. And I'm going to invite our next speaker. Laura Mann is the Global Head of Sustainability in the Corporate Affairs Partnership and the Chair's Office at AstraZeneca. Thank you so much, Laura. Over to you.
Thank you so much, Daniele. Can you hear me okay?
Yes, perfectly.
Super. Hi, everyone. It's lovely to be with you today. My name's Laura Mann, as Daniele just said, and I'm speaking today on behalf of both AstraZeneca and also a fantastic collaboration called the Sustainable Markets Initiative. So pleased to share updates from a company perspective as well as a coalition that I'm very proud to be part of. Okay, let's get going. I know we haven't got very much time. So maybe just to first of all ground us and share a little bit of an introduction as to AstraZeneca for those who don't know about us. We are a large multinational biopharmaceutical company, very much science and innovation driven. We have three therapy areas that we focus on, although perhaps are most known across the world for the vaccine, the COVID-19 vaccine effort that we led, where we delivered millions of doses of vaccine at no profit. But actually our core business is around oncology, cancer medicines, biopharmaceutical medicines and rare disease. And we really aim to get medicines to patients around the world with our 90,000 strong employee base. Something that AstraZeneca is also very well known for, which also makes us very proud as employees, is our commitment to sustainability and to helping to improve not only the health of people around the world, but also our society and planet. And I guess the context is clear, and I know there have been many presentations before this one, but I'll just perhaps give a few highlights from our perspective. The reason that we focus on sustainability at AstraZeneca as a pharmaceutical company is because that we recognize that the climate crisis is worsening the burden of disease with a steep rise in non-communicable diseases as well as infectious diseases. Okay. We know also, particularly post the pandemic, that health systems are increasingly unable to cope with the rising demands of aging populations, the rise in NCDs, also other health challenges around the world and comorbidities faced. And we also know that, unfortunately, there are many health inequities around the world, both within high-income countries and low-income countries. And we know that with more of a focus on early detection, screening, optimal treatment of disease, that the 80% of premature deaths from non-communicable diseases that happen right now could be prevented. We also believe that healthy people are at the heart of a healthy society and economy, and that there is a significant, multi-trillion-dollar burden of the disease challenge that we face today. So actually, improving health is good for people's lives, livelihoods, communities, but also economic productivity as well. So that's the context, and this is why this topic is so important to us, AstraZeneca. A quick overview of our sustainability strategy as a company. We are focused on how we can make a positive impact on the world around us through an integrated approach to climate and nature action, health equity, and health systems resilience. And at the same time, we want to run a sustainable business so that in 10, 20, 30, 40 years from now, we can be continuing to discover and develop and ensure access to medicines for patients all around the world. So we see these as integrated and interrelated, the external impact that we have and how we run a sustainable business. And a couple of examples of what we're doing as a company. We have an over $1 billion commitment to accelerating the delivery of net zero, science-based net zero by 2045. We are decarbonizing our manufacturing and research and development sites across the world. And also, we are leading in sustainable science. So, how do we discover and develop medicines in the most environmentally friendly way possible? We also have significant targets for our suppliers because we know that we can do all we can within our own sites as a business. But actually, the value chain emissions and footprint is significant. So there's a lot of work that we do there. We also focus very much on health equity, recognizing that the climate crisis is also a health equity crisis. And again, we want to make our medicines more equitable and available to more people around the world. And we also lead a key partnership or co-lead that I'll come on to, which is really aiming to help strengthen health systems so that they don't fall over or collapse as many did during the COVID-19 pandemic. So we work there with the London School of Economics, Philips, the World Economic Forum, and many others, and are active in this resilience program across 30 countries globally. Okay. So a couple of examples of our impact and our collaboration. One which is really important and at the heart of our business is our respiratory sustainability work at AstraZeneca. And one of the key medicines or areas of medicine that we specialize in at AstraZeneca is inhaled respiratory medicines. But we know that they have an, although very limited, 0.04%, these PMDIs that we produce, the pressurized metered dose inhalers for asthma and COPD, do have an environmental footprint. And so we've invested over $500 million in transitioning this portfolio to a next generation propellant, which has a 99.9% near zero global warming potential. And this is actually already approved in the UK and recommended in Europe. So this is one of the ways in which we're investing significant dollar figures to really develop more sustainable medicines, because we want to ensure that respiratory patients have the access to the medicines that they need, but also medicines which have an improved environmental footprint. So that's something that we're very, very proud of. At the same time, we also recognize that we can have a really strong impact, a positive impact, both within our company, but also when we partner with our peers and others across the healthcare ecosystem. And that's why our CEO, Pascal Soriot, chairs a coalition called the Sustainable Markets Initiative Health Systems Task Force, which was founded by King Charles III at COP26. And we're really pleased to be joined by ever-growing, I think we're now 15 members at the global CEO level, who are all committed to accelerating the delivery of net zero health systems. And we focus on 4 areas: decarbonizing supply chains, patient care pathways, leveraging digital healthcare in clinical research, and also consumer health and well-being. And it's a fantastic initiative where actually, we recognize that we can do much more when we come together, and where we also are collaborating with others like the NHS, World Health Organization, and several academic partners, as well as pharmaceutical and healthcare companies. And so to inform where this collaboration has really focused its efforts, we did a lot of research and mapped the footprint of the healthcare value chain. And we found that about half of the emissions come from making and moving medicines. A small amount come from R&D, but then around almost half come from patient use of medicines and patient care settings. Just like in the previous presentation, the cooling and heating of hospitals, for example, use of anesthetic gases, trips to and from the hospital in cars, etc. These all create emissions. And this kind of mapping has helped to inform our efforts. And so I won't go through all of this. This is a busy slide, but some of the goals that we have are to engage with our suppliers and to onboard them to green power and heat solutions. Also, our chief procurement officers are come together to take a joint approach to Scope 3 emissions. We've created renewable power purchase agreements, for example, in China, which we've already expanded and which we welcome any other company with a significant load value in China to join. We've created almost a platform for companies within and without and outside of the healthcare company to access renewable power in China at a reduced premium. When it comes to patient care pathways, we're actually soon to launch a global standard for life cycle assessments for medicines, so that for the first time in a standardized way, we can measure the footprint of medical products. And we're engaging health systems and the sector with an aim of greater adoption. We're working on a really exciting program with universities that I'll come on to in a moment. And then also colleagues are working very closely with the clinical trial community on how to decarbonize clinical trials. And colleagues from Bupa and Reckitt and Sanofi are also working with a cities network on how cities can prevent and adapt to the health challenges of climate change, with some key recommendations and a city leader network. So as you can see, there's a lot that we've actually done in the last 4 years that we're really, really proud of. And this is really about action, not words. Very briefly, the education initiative that I just talked to a moment ago is something that I'm personally very proud of, and where AstraZeneca and our key partners has worked closely with the University of Glasgow, Columbia with the Global Consortium for Climate and Health Education, and others to launch a network in Europe, which started with 25 universities last year and is now at over 40 universities, where the medical schools have committed to delivering education on sustainability within the curricula of medical students at the undergraduate level. And already within just about a year since we launched, actually, we have a number of initiatives underway led by universities, but with some kind of support from companies to enable them to do this. So this is really exciting. We aim to reach over 10,000 medical students across Europe by 2027. This remains also open for any other universities in Europe to join. And finally, I mentioned towards the beginning of my presentation, this is my last slide, another public-private partnership that we're very, very keen to be a co-founder of, alongside the Sustainable Markets Initiative Health Task Force that I just talked about, is this one. It's got quite a long name, the Partnership for Health Systems Sustainability and Resilience, or PHSSR as we call it. And this is a group that AstraZeneca co-founded with the WEF and the London School of Economics to demonstrate and use in-depth policy research and academic research to produce data-led policy recommendations on how health systems in 30 countries can become stronger and more resilient in the long term. And this has been a very successful program. As you can see, all the countries in purple have this program active there, and it continues to grow and expand. This is really about making sure that our health systems are fit for purpose and can treat the patients that need their support. So I hope those are just a few crystal clear examples through the respiratory sustainability, the inhaler example, the SMI and the PHSSR, of how we are really committed to driving action, not only as a business, but beyond our company walls and across the healthcare ecosystem. Thank you so much.
Thank you. Thank you so much, Laura, for this presentation, and for sure that the Sustainable Marketing Initiative is a very interesting initiative that collaborates private sector with other institutions, and I have many friends very impressed with how AstraZeneca is sustainable in the company and in many different aspects. And before we go to the discussion, I would like to invite Rida Sadiq to share with you, all the participants, an initiative that can be the next step after this training. And it's going to be very quickly, and then we can go to the final discussion. Rida, over to you.
Thanks, Daniele. So yes, okay, wonderful. Yeah, so I'm Rida Satki. I'm the executive director of the Geneva Learning Foundation. I'm going to try in 5 minutes to give you a quick overview of 3 opportunities coming out of this course. One is a certificate peer learning program. The second is called Teach to Reach, and the third is really a network for leaders and organizations across the world with over 4,000 organizations participating. So just to give you a sense of what the Geneva Learning Foundation actually does, it's really about learning by and for health workers. And here we reach currently around 70,000 health workers, primarily in West and Central Africa, Latin America, and Asia. And you can see the curve of participation in one of our peer learning events called Teach to Reach. Now, starting in July 2023, we asked this question. This was to this network. This is a sample of 1,234 responses, and this is what the perception by health workers that climate change is indeed a threat. So based on this was our starting point to develop a complete certification program. You can find it, and I'm going to start sharing the some of the links in here. Let me just see if I can do this well. Okay, I may not be able to, but anyway, yeah, you can find it at learning.foundation/climate. Now, this is a complete program. I'm just going to tell you about the first course, and it's called Learning Together to Lead Change on the Front Line of Climate Change and Health. We're actually starting the course on Monday, but the good news is that you can absolutely join late if you must. What this will do is not only provide you with experiences from health workers all over the world that have been shared before, but you'll also be invited to share your experience, your observations about what is changing, what are the impacts of climate change that you see on health, and then you'll hear back, giving and receiving feedback to others. Now, this program is more than just this one course, but that course is a starting point, and it's really about turning your ideas, your experience, what you see, and your motivation, your engagement to actually make a difference into action. The centerpiece of the program is called the Impact Accelerator, and this is where you actually take all of the knowledge, the skills, the competencies, the reflection, the thinking, the partners, the networks, everything that you have, and actually working with others, connected with thousands of other health professionals, actually make it happen, actually take small but significant steps to move forward. So that is the course starting on Monday. The second opportunity is called Teach to Reach, and Teach to Reach is this ongoing, continuous learning platform where really you can be answering questions, tapping into your own experience, and then receiving back the experience of this global community of people who are really on the front lines of climate change and health. There are benefits for individuals, for participants as an individual. Learning through dialogue gives you all kinds of things, such as discussing real world situations with people who may be in contexts very different or very similar from yours. And also it's really an opportunity to build your professional network. So unfortunately, I'm not able to share with the links, but I believe they've been shared with everyone in the course. And then there are also benefits for organizations. And this is really out of Teach to Reach or around Teach to Reach, grew a network of over 4,000 primarily locally led organizations in low and middle income countries. But we're very interested in connecting with organizations from the global north and seeing how we can really work together and connect with each other. So this is peer learning for health leaders. I can't share the link, but I myself, but I can share the QR code. So I'll end with that. You can learn more about the program. It's quite different from the didactic transmissive learning, and it's really the perfect complement. Once you have the knowledge, the best available global knowledge, connecting with your peers through dialogue, through sharing experience, giving and receiving feedback can be a great next step, at least for some folks. And for people who have bandwidth challenges, we have a podcast where you can actually listen. It's like radio sort of on demand. So I'll stop there and wish to thank the GCHE team and all the partners involved for the opportunity to present. Thank you.
Thank you so much, Rita, and to share your initiative and also to share these opportunities with the participants. And I think you should take a look on the Geneva Learning, and it's good for building this community of practice and to share knowledge. So I will make a questions for each of our presenters. We don't have a lot of time, and it's the final session, and we have some final message to our participants as well. So I have a question here for Judith. How can we combine modern climate adaptation needs, such as energy efficiency or rainwater collection, with preservation of traditional architecture? And another question, I think it's related to this, what would be constructive recommendation for the health infrastructure? I think this one is regarding for a new hospital. What is the recommendation that this building can apply?
Thank you. I'll begin with the second question. The Smart Hospitals Toolkit, which is being revised currently and which is on the PAHO website, Pan American Health Organization, contains, and particularly the new edition will, a checklist for construction of smart new hospitals, ranging through the issues that must be considered in order to achieve that adaptation and mitigation of climate change. And it is linked to a document, Sustainable Construction of Hospitals. So I won't go into the details, but I'll tackle the second question to do with the traditional architecture. And it is true that there are photos, for example, of Dominican traditional buildings which survived very strong hurricanes. So the features of traditional architecture, such as the shape of the roof, the nature of the windows with the shutters, the ventilation, are very well adapted to climate change. But the fact that they are vulnerable to fire means that most traditional architecture in certain communities, such as Castries, St. Lucia, has been lost to fire. And not only that, but the traditional architecture, and I speak of wooden buildings as this example, is vulnerable to the elements decay under tropical conditions. So a lot of traditional architecture has not survived due to problems like this. And therefore, there is a case for referring to modern technologies and materials to enhance the learning from traditional architecture. Thank you.
Fernando, do you want to complement?
Yes, I will complement, if I may, in Spanish. Creo que
Well, I
en
think
América Latina y el Caribe
in
debemos de
Latin
entender
America
que
and the
ya
Caribbean,
existen
we need
procesos
to
de adaptación
understand that there
en
already are
las zonas
adaptation processes
donde
in
se encuentran
place
comunidades
in the
nativas,
areas where
y
there
es
are native
importante
communities.
reconocer estas
And it's
medidas que han implementado
important to
y
acknowledge these
entender
measures
cómo se puede
that
llevar
are
un
already in
proceso de
place and to
innovación
see
con
how
lo
we
que
can
se
bring
investiga en la academia,
innovation
en las
with the
universidades, qué
research that
funciona
is
y
done
qué
in
no funciona,
academia, in
pero sobre
universities,
todo
on what works
ir
and
con
what
la
doesn't,
mente abierta
but
y
it's
explorar
mostly going with an
con las
open mind
comunidades y
and
con el
exploring
gobierno lo
with
que
the
puede
communities
funcionar,
and with
no
the
solo en
government
cuestiones de
what may
infraestructura,
work or not
sino de
just on
desarrollo de
infrastructure
capacidades
issues,
de
but
adaptación
also
y de la
for
comunidad como
building
tal.
capacities for
Y también
adaptation
otro
in the
elemento que me
community.
gustaría recalcar es
And
que
something else
ya
I
hay
wanted to
países que tienen
highlight is that
normas de
there are
edificación
countries that
sostenible
already have
que se
sustainable
pueden explorar
building
para poner
standards
algunos
that can
ejemplos.
be
Ah, mira, en
explored
Chile
for
han
examples.
implementado esta
For
norma
example,
técnica.
look, in
Ya hay
Chile, they
ya
have this
ciertas guías que
technical
te mencionan
standard
qué de esto
and
nos
there are some
funciona a nosotros.
guidelines.
O en Colombia, que
What
es un
of
país que
this
tiene
might work for us
zonas
or
más
not? Or in
tropicales, que ha
Colombia, for
funcionado,
example,
o
that
en
has
Cuba.
more tropical
Entonces, tienes la
areas,
oportunidad de
or in
explorar
Cuba. And so
bajo
you
las
have the
normas técnicas
opportunity of looking at those
cómo se
technical
puede adaptar a las
standards
necesidades de
to
tu
look for
establecimiento de salud.
ideas for adaptations.
Thank you, thank you. I will continue with you. There are some questions regarding to nature-based solution and vegetation. So someone said, doesn't the vegetation around the health infrastructure attracting insects or rodents? and that could affect the sanitary functioning of the facility. And the other one is, what examples of nature-based solutions can be applied to hospitals?
Yeah, so I responded directly to that message in the chat, but just to share with you also in English. Of course, vegetation can give those maladaptation results. No, that's how we call it, maladaptation. So it's very important to see with a proper specialist what are the vegetation that is the best for the area, for the zone that you are trying to include the vegetation. But also very important, you must have the capacity to have the maintenance of that urban gardening. And that means like how are you going to take care of the pests if it comes, and to identify options that are natural or organic to deal with those pests. In Latin America and the Caribbean, there are natural ways that we have identified that are used for this. And what was the second question? Sorry.
The second, it's about how examples of nature-based solutions that can be applied to hospitals.
Oh yes. Well, since you can have like internal what we called biophilic architecture. So you can find a specific nature vegetation that can be inside the hospital, considering the level of light and considering the level of shade. You can identify what are the best places to include this kind of vegetation. Of course, there will be places that you cannot have this kind of vegetation. There are some places that are um, more that are better, and like in the external outside the boundaries of the health facility, you can have the urban gardens as I was presenting, and you can have also reforestation activities. So there are a lot of examples that health facilities work with the community and work with the local government for reforestation activities that provides these co-benefits on mitigation and adaptation that we have already presented. Thank you.
Thank you. And I
If you
have
don't
a
mind, I'm
question.
just if I could jump on that one from a bit more northern perspective in Canada. Yes, we have insects in Canada. We have had people concerned about bees, for example, but native bees in Canada are not very aggressive, and so we have to reassure people about that. And in terms of what you can bring to a hospital, I mean, if you look up websites on this, on natural-based solutions for cities, I mean, it would be the same for hospitals. You can create green roofs, rain gardens, plant trees, pollinator gardens, as I mentioned, which are native flowers and grasses, etc. And ideally, you have a landscape architect involved who is thinking through, these challenges that you're mentioning. Sometimes you don't, and then what you really need to do is make sure you're staying with what we call native species, or species which are native to the area that you're living in, and not bring in invasive species. Thank you.
Great. And I have a question that can be both for you, Miles, and also for Laura. Have more sustainable alternatives for medicine packaging being studied? This is easy.
Hi there. Yeah, very happy to jump in here. So I think a great example that we've been advancing across our global business at AstraZeneca is a pivot to something called electronic product information. So, when you have a packet of medicines and in that packet there is a leaflet, and most people chuck it in the bin. They don't read it. The text is tiny and it's not often used. You can save not only reams and reams of paper. Think of all the paper you could save across the world with this, but actually you can get medicines to patients quicker and in a more accessible way by putting that information online electronically. So when you have a QR code on the box of your medicines, and you can scan it, and that means that the information can be made available in different languages in real time. So if there's a safety update or there's some new information that has to be made available to patients about the medicine, that is in real time. And because of that, we know through our practices around the world that we've, for example, in Singapore, got some medicines 3 months earlier to patients just by getting rid of the leaflet and doing things online. Of course, that means if you're maybe an older patient, you don't have access to a smartphone, etc. You, of course, need to have access to the printout, and we're working with pharmacists on how to do that. But this is a great example of saving paper, saving time, saving money, and actually getting medicines to patients quicker. So that's just one way. And then also through the Sustainable Markets Initiative, we're actually looking at whether we can work together, for example, across Europe as a pilot, on a take-back scheme for certain types of the external packaging of medicines, where we can work together and actually make that something like with water bottles or other types of things that people recycle now as a habit. Can we do this with some elements of medicine? That requires a lot of collaboration across the industry and across the healthcare ecosystem. Thanks.
Amazing. So
Sure,
soon
I'll
we
jump
have
in, and I'm
more
curious, Laura,
sustainable.
are you
Yeah, go ahead.
are you okay? Yeah.
Yes.
Okay, thank you. Yeah, Laura, are you busy later? Can we chat?
We can sure chat. There's a lot to talk about. Yeah, we'd love to
Yes.
take you up on it, Miles. We do a lot with the Canadian authorities, so it'd be great to partner. Thanks.
Right. So a couple of things there. One, I know that someone is doing a project in Canada on the use of glass bottles in an outpatient setting, which would be pretty cool, instead of plastic. I mean, if you just think about all the plastic that we use worldwide, both for over-the-counter meds and prescribed meds, I mean, it's kind of mind-boggling. I think a lot about medication waste, and that we can do better on that side as physicians. I could use iron tablets as an example. We have typically prescribed iron tablets 2 to 3 times a day for people. Iron tablets, if you've ever taken them, often cause gastrointestinal side effects. But it's now been found that iron tablets can be absorbed almost as well, just taking them once a day or every other day. And think about the amount of waste we would be getting rid of if we did it that way. And one other quick one on the waste side of things is the things that happen inside hospitals. I could just talk about Canada. If someone comes into a hospital in Canada and needs an inhaler for like an asthma exacerbation, they will get an inhaler in the emerge department. And in a lot of hospitals, when that patient is then admitted because they're still sick, the product they got in the emerge department gets thrown out. They get a new one when they move upstairs to the ward. So that might be a product that had 200 puffs in it. You only used 5. You threw it out. You get a new one. In the case of going to long-term care's nursing home, same thing. Medications do not follow the patients. Ton of waste there. So we're trying to do something about that in Canada.
Amazing. Thank you so much. So soon we will have some solutions for these issues. And I would like to thank you, all of you. And I will finish this session, but I would like to share some numbers with all our participants. So in this course, we received 2,700 registration, and we have 824 people in our WhatsApp group, and please continue in the WhatsApp group so we can share with you new initiatives. And we have participating in this course at least 1,700 people who watch at least one session. So this is an amazing numbers, and I really would like to thank you, all of you. And as we come to the end of this 11 session journey, I really would like to express my thank you to all the speakers, all the moderators, and the participants, and our partners, the Health Canada, the WHO, the Pan American Health Organization, the Inter-American Institute for Global Change Research, the Ministry of Health of Brazil, the Earth Medic, Earth Nurses, and the UN universities. We discuss here how to prioritize actions that safeguard communities in a more severe climate regimes, how to apply existing guidance to promote equity and inclusion, and how to build partnerships. And we saw here, like live, a partnership that's going to to be concrete soon between AstraZeneca and the green the Canadian Green Coalition. And so this course was prepared many of you to bring these lessons and also to bring these lessons into a global forums. We are close to the COP30, and all the things that you learn here and that we discuss will be fundamental to be discussing at the COP, and also to engage meaningfully in shaping the global goal on adaptation. That's the new agreement that is going to include health as a sector and also health indicators of adaptation, and we need to advance in this sense. And I would like to thank you, everybody, for your dedication, for the knowledge you share, and for the work that we do together. And we'd like to remember that resilience is more than about system, it's about of people. So each of you plays a vital role in ensuring that health remains at the center of the climate actions in the Americas. So thank you so much. And we see you in another initiative that we can have. Thank you.